I want to pivot to our last section because this is our largest section. This is probably the area where we're seeing the biggest changes in the field now and in 2020. And this is in metastatic castration-resistant prostate cancer. And so, just to set the stage, I mean, we're all aware of the progress that's been made over the last 15 years with taxanes, docetaxel, and really in just the last 10 years with a number of newer agents, cabazitaxel and Sipuleucel T and radium and over the last 7 years or so our androgen targeted strategies, abiraterone and enzalutamide, in this metastatic castration-resistant setting. But there's some new developments going on in the field, and we're beginning to understand a little bit more about sequencing of drugs and recognizing the impact of that. Because, when we sequence from one drug to another, that in one of those agents doesn't work, we've essentially delayed the time to the next kind of therapeutic benefit. And as Chuck, mentioned earlier, I mean, that those delays can have significant impact on overall survival. Even, we've learned that from some of these crossover studies. So I want to spend some time talking about that. These are sort of a field now of drugs that, we're recognizing we're moving beyond sort of the one or two classes of agents, and into a field now where we have multiple targeted agents, and we may get some newer targeted. We've just gotten some newer targeted agents with PARP inhibitors. We're getting potentially new targeted radiopharmaceuticals in the future. These classes of drugs are going to continue to expand, and it's going to be ever more important that we make the right decisions in terms of the order and sequence or combinations in the future. So let's dive into some of the data that's come out in the last 12 months. And the first couple studies, I think they were presented primarily at ESMO, but I think they're still relatively fresh on our minds in terms of their clinical implications, are the CARD study and the PROfound study. And Tanya, I wonder if you could walk us through these studies and give us your initial thoughts on the clinical implications of these results.
Sure, Dan. The CARD study, I think, was super practice changing for me personally. This was a study in which men with metastatic castrate-resistant prostate cancer who had already been through abiraterone or enzalutamide were randomly assigned to cabazitaxel or the opposite AR targeted therapy, the abiraterone or the enzalutamide, which was the physician's choice essentially. And what the study showed, and I should mention these men had also received docetaxel. What the study showed is a significant prolongation in radiographic progression-free survival, which was the primary endpoint, but also a trend towards overall survival, 11 months versus for AR versus 13.6 months for cabazitaxel. But what really struck me, and you alluded to this, is they had a significant improvement in pain. So one thing that was unique is most of the patients getting onto this study had not progressed just by PSA. Something like 70% of them had progressed based on pain, so symptomatic progression. So that's a little bit unique when we're thinking about how to apply these data in our practice. But given that so many had pain, 45% of the cabazitaxel patients had pain benefit or pain relief compared to 19% on the Abi or Enza. So we're not only trying to help our patients live longer, but I always emphasize we're trying to help them live better. And that can be counterintuitive when you're thinking about chemotherapy. A lot of patients think of chemotherapy as something that's going to make them feel worse. So I think emphasizing that when we're picking not just to help people live longer, but really to deal with the palliation, to control symptoms and skeletal related events. Again, not to beat a dead horse, but that's really what drives morbidity in this disease. And overwhelmingly, these men suffer from bone metastases. So I found it very compelling. And then you have PROfound. So this was also, to me, very exciting to see a new class of agents, PARP inhibitors, go head-to-head against a second-line Abi or Enza. Again, this was a very similar population that had progressed through one of those agents, and the control arm was physician's choice. All of these patients had to have a DNA repair mutation, primarily BRCA1 and 2, but there were also ATM, FANCA, PALB2, CHEK2, and a number of other mutations that were eligible. And to find a progression-free survival advantage and overall survival benefit and with an active comparator, to me, is just really exciting. No more placebo control here, but what we would consider a fairly active alternative choice. So this really establishes the role for PARP inhibitors and speaks to the need for genomic testing and genetic testing in these patients, both germline and somatic. We need payers to cover this because there's a real survival implication for patients if we discover these mutations.